Hi, my name is Nailan Appana. I'm a specialist gynecologist in Hamilton in New Zealand. Welcome to my series of educational videos in gynecology. Today we're going to talk about endometriosis. So what are the implications of having endometriosis? The course of the disease is extremely unpredictable. While some women develop a few isolated spots that never spread or grow, others may develop severe disease throughout the pelvis and abdomen. Endometriosis can produce web-like growths of scar tissue, called adhesions. The scar tissue can cause pelvic organs to stick to one another and contribute to the pain that occurs with endometriosis. The amount of pain is not proportional to the amount of endometriosis. This may be because of the proximity of the endometriosis, blood, and scarring to nerve fibers, as well as the individual's inflammatory response to endometriosis. Psychological implications. Endometriosis has considerable emotional consequences for women. The pain is debilitating and affects work, relationships, disrupting normal activities. Loss of libido due to discomfort with intercourse is common. The hormonal treatments for endometriosis can also affect sexuality and cause mood changes and emotional imbalances. Some of these medications cause a medical menopause, causing depression and inhibiting sexual desire. Support groups play a vital part in helping women with endometriosis. In Hamilton, we are very lucky to have Insight Endometriosis, which has been formed to help women with endometriosis. The understanding and support of a partner, family, and friends are important to any woman with endometriosis. Infertility. Infertility is unfortunately a symptom of endometriosis. Not all women with endometriosis are unable to conceive, and one should not presume that endometriosis is the cause of the fertility issues. Other factors should also be considered as a cause of infertility. Most patients with endometriosis are not infertile, but subfertile, which means you may take slightly longer to conceive than the general population. It is my experience that conception rates increase dramatically in the first year after excisional surgery for endometriosis. Endometriosis inhibits fertility by scarring and adhesions may bind the ovaries, fallopian tubes, and intestines together. This may also interfere with the release of eggs from the ovaries, or the pickup of the egg by the fallopian tubes. The ovaries may be stuck well away from the tubes, so that the tubes are unable to reach the ovaries to pick up the eggs at the time of ovulation. However, even if there is no damage to pelvic structures, endometriosis can still inhibit ovulation. There is evidence that something, perhaps prostaglandins or other chemicals, produced by these implants, interfere with ovulation, entry of the egg into the tubes, and fertilization. An altered immune response has also been postulated as a possible cause for the infertility. Miscarriage. The risk of miscarriage is higher for women with untreated endometriosis than in those without it. The increased risk does not seem to be present in women who have been treated. The reason for this is unknown. However, it has been postulated that chemicals that can be toxic to the embryo, which have been found in the abdominal fluid of women with endometriosis, may be the cause of this. It is also postulated that an immune system response may explain the risk. Economic consequences. Endometriosis is a disease affecting millions of women. The incidence is 0.5 to 5% in fertile women, and 25 to 40% in infertile women. There are profound economic consequences and significant impairment in the quality of life. It is estimated to affect 8.5 million women in America alone. Nearly a decade ago, it was estimated that the total cost of care for women with chronic pelvic pain was substantial, with 15% of women missing an average of 15.8 hours per week, per month, in the United States alone, accounting for a staggering $14 billion in lost productivity each year. The cost of medical, surgical, and psychiatric care or hospitalization were assessed at $128 billion per year. This is likely to have increased substantially. Here are some other important facts more relevant to general practitioners. Chronic pelvic pain. It is estimated that 41% of all women with chronic pelvic pain have endometriosis. Histological diagnosis. If endometriosis is seen at surgery, then it is nice but not necessary for the diagnosis to have histological confirmation. Up to 30% of biopsies with clinical evidence of endometriosis come back without histological confirmation. Rectovaginal nodule. If scarring is felt by a gynecologist behind the uterus, that is, between the back passage and the uterus, then up to 25% of these women will have a problem involving the bowel, and 2 to 3% will require some bowel removed. This is not proportional to rectal bleeding as a symptom. Time from first presentation to diagnosis. The average time from first presentation to diagnosis is 6.9 years. This increases to 9.5 years when the first presentation is earlier than 20. Infertility patients have a shorter time frame of 4 years to diagnosis. The average number of visits of women to the GP for any reason in general is about 3 per year. In the year prior to diagnosis, the average number of visits to the GP is 11. So who gets endometriosis? It used to be that we are seeing endometriosis in women in their 30s and 40s, but we are now seeing it as early as 14 and 15. Most patients are now diagnosed in their mid to late 20s. Nulliparous women, or women who started their families later, are also more prone to the disease. Of course, women with the classic triad of pelvic pain, dysmenorrhea, and dyspareunia should always be considered. Diagnostic tests for endometriosis. Studies have shown that at curettage there is an increased amount of nerve fiber growth factor and nerve growth factor receptors, as well as an increase in nerve fiber density in the superficial layers of the endometrium in women with endometriosis. Whilst we know that this is a normal inflammatory response in other areas of the body, this effect could not be reproduced in any other condition, including endometritis and other chronic pelvic inflammatory conditions. Further investigation is necessary, but this looks promising as a relatively non-invasive method for diagnosing endometriosis. Adolescents are a difficult group in endometriosis. Mirena use in adolescence. This is not uncommon and is now a method being trialed by many gynecologists after failed oral contraceptive therapy. Combined oral contraceptive therapy is still the first line of treatment in the adolescent with dysmenorrhea. The MDOT study is a study conducted in Canberra, Australia, in schoolgirls aged 16 to 18. 1,051 out of 1,071 completed the study. The prevalence of significant menstrual disturbance in the sample population was 25%, with 21% having severe pain. 26% reported absence from school for the pain, and 33% having seen a GP about a period problem. Investigation of the menstrual pain and symptoms, referral and diagnosis of pathology was very low. IVF and endometriosis. Should patients be treated? There is absolutely no doubt that there is an improvement in spontaneous conception rates as well as assisted conception rates in women with grade 1 and grade 2 endometriosis. Benefits are highest in the first 2 years after surgery. Grade 3 and grade 4 endometriosis are still open to debate. Risks at IVF are definitely reduced in patients having had this treatment. Endometriomas. Should they be removed? Every time an endometrium is removed, the number of residual oocytes in the ovary is decreased. There is no doubt that the number of eggs harvested from ovaries where an endometrioma has been removed is less than that from the opposite ovary. However, this is also true in ovaries where an endometrioma is present, where the number of oocytes from an ovary with an endometrioma is less than from a normal opposite ovary. The general feeling is that endometriomas of 4 cm or more should be removed, but no one can say how the number of 4 cm has been arrived at. Endometrioma origins. It was thought that endometriomas grow from the pelvic sidewall into an ovary. There is now some proof that they may in fact develop from a hemorrhagic corpus luteal cyst, or that they are transmitted via the tube and implant on the surface of the ovary and grow inwards. Recurrence of endometriomas. If an endometrioma is present, up to 30% of women will have a recurrence of the endometrioma within 2 to 3 years of surgery if there is no further treatment. Cancer and endometriosis. There is a significant link between endometriosis and cancer of the ovary. 7 to 14% of women with ovarian cancer have endometriosis. Conversely, 0.3 to 0.8% of women with ovarian endometriosis may go on to develop ovarian cancer. This chance of ovarian cancer is doubled if the patient has extra-ovarian endometriosis. The chances of cancer of the ovary are quadrupled if a patient has ovarian endometriosis. 250 to 300 women per year in the UK develop ovarian cancer from endometriosis. Endometrial cancer may also occur in endometriotic deposits, although this is uncommon. It has even been shown to occur in endometriotic abdominal wall implants. Patients treated with danazol had a threefold increase in endometrial cancer as compared to those treated with gonadotrophin-releasing hormone analogues. Excision versus ablation. There are still some gynecologists performing ablation for endometriosis, although studies have now conclusively shown that there is a significant benefit to excisional surgery as compared to ablative methods, i.e. diathermy, laser, etc. Even using the KTP laser, which is laser absorbed by pigmented tissue, there is an 18% versus the 6% 12-month recurrence rate with excisional surgery. Disclaimer. Without having examined you personally, it is impossible for me to make a diagnosis or advise treatment. All information provided here is generalized and for educational purposes only, and decisions based on this should not be made without consulting your own medical professional. I assume no responsibility for you taking advice rendered here without me having had a physical consultation with you. I assume no responsibility for you following advice rendered here without me having had a physical consultation with you.